لا إله إلا الله لا إله إلا الله لا إله إلا الله ما لنا رب سواه.
Thank you for having me, and thank you for that introduction, Bassem. Okay, so I'm going to talk about leadership in a hostile work environment. And as I get into the story, you're going to understand what a hostile work environment is and why exactly we need to talk about, give me one second, why exactly we need to talk about leadership. Okay, I use my hands a lot, so, okay. What are we going to learn today? So we're going to talk about what constitutes a hostile work environment. What exactly does that mean? We're going to describe the impact a hostile work environment has on both patients and healthcare workers. We're going to talk about the importance of having difficult conversations in navigating these hostile work environments. We're going to learn strategies to lead those difficult conversations and in challenging these hostile work environments. And then we're going to look at the power of embracing difficult conversations and its impact on the workforce. So I'm going to start with a story. So this is my first year out of fellowship. I'm on call and I get a pager, go down to the ER, and we have a trauma patient coming in, level 1 trauma activation. 65-year-old woman had a motor vehicle collision where one person died at the scene. Her blood pressure en route to the hospital is 90 over palp. She comes in and we do our thing, right? So what does low blood pressure in a trauma patient mean? Hypotension, tachycardia. 90 over 50, say. What does it mean?
Hemorrhagic shock.
Hemorrhagic shock. That's the number 1 cause. What's the second cause? Hemorrhagic shock. Exactly. What's reason number 3? Hemorrhagic shock. Very good. That's your trauma lesson for the day, okay? So an unstable trauma patient is bleeding until proven otherwise, okay? They're bleeding somewhere, and your goal is to find the bleeding and stop it. So we get the patient on the board. EMS gives us their report. We put the patient on our bed, and as a trauma surgeon, it's my job to lead that trauma. Okay? So I say, okay, let's start 2 large bore IVs. Our first blood pressure is 80 over 50, and her heart rate is 120. And so I said, okay, 2 large bore IVs, give a blood transfusion, get a central line kit ready so I can do a central line if we don't have IVs. And the room is moving at a very slow pace. It's as if we're in a regular room doing a regular checkup. There's no sense of urgency. So I restate, guys, we have a patient who's unstable. Let's move a little bit faster. So they don't respond. There's no comment. There's no "we heard you." There's no closed loop communication. None of that. We check her blood pressure again. It's 70 over 40, and her heart rate is now 130. So what's happening? Say it again. She's bleeding to death. If we don't intervene, this lady's heart is going to stop, and what am I going to have to do? Do we do CPR in trauma? What's CPR in trauma? Nope. What? Thoracotomy. You're going into surgery, aren't you? Yes. So a trauma patient's heart stops from bleeding to death. We do an ED thoracotomy. An ED thoracotomy is we cut the chest open and we do open cardiac massage. We do CPR directly on the heart. Okay? So your job is to keep patients from bleeding to death so you don't have to cut their chest open, because that is morbid. Okay? So I ask again, this patient is bleeding to death. We need to move faster. Fine. We heard you. Okay? Chill. That's the response I get from the lead charge nurse in the trauma room. So what would you do? Anybody, what would you do in this situation? Lose my mind. Okay, you lose your mind, everybody else in that room loses their mind, because as a leader, you set the tone. Okay, what else? So we're not gonna lose our minds. Internally, yes. Okay, what else? What would you do? So how are you gonna continue on? Because you're trying to tell them what to do, and they're supposed to carry out your orders. They're not carrying out your orders.
I think I would just clarify to her the situation that the patient is about to die and is bleeding, or we're not moving fast
apparently or clearly that we need to move faster where we are right now.
Okay, Doc, I heard you.
This is really bad, but I'd probably speak louder than I should be.
That happens a lot. Where we raise our voices, we get angry, right?
You need to lose the attitude and do your job.
You know what? You might have a clue. Yes. We're going to get there. Yes. Who else?
I was going to say just do it, like start doing it yourself, and hopefully that will get you to the
So that is actually something very important in trauma. As a trauma lead, we have a spot to stand. Because if I go into detail and start doing the IV, who's managing the whole thing? Who's managing the room and the patient? Right? Your job as a leader is not to do the job when somebody fails to do their job. Your job is to figure out why they're failing at their job and get it done. Your job is to figure out why that's not happening. So as a leader, you can't say, oh, you're not doing your job. Okay, let me do your job for you, right? And let me see if I can figure out how to put a level 1 together and see which goes where. Let me see how to do an IV. I could do a big central line right away, right? If they can't get it, but you can't, as a leader, take on somebody else's job to get things moving. There are times you may have to, but in this case, you have to be aware of everything that's going on with this patient. So anybody else?
assign a specific person that job, like finding.
Yes, clear directions, yes. She's the only person there. It's 2 a.m. So we're gonna have this discussion, patient's blood pressure's 60, it's 65 and we can't feel the diastolic. Now heart rate is 150. Oh, and she flatlined. Now you have to do a thoracotomy and somebody get me the stuff and they're like, okay, let's get it from the operating room.
If they give me attitude like that by saying what they said, I would just say, okay, good. Because they said, oh, I heard you. I would say, okay, good.
Okay, all right, very good. You guys have a lot of ideas, but you over there, you would tell her cut the attitude, huh? Okay. We'll get back to you. Okay, so like in my head, I'm losing my mind. In my head, I'm like, what is going on? And in my head, it's how did I get here? How did I get into a position where I'm entrusted with somebody's life and I can't even get my team to do the job? So I've been at this institution for about 6 months now, and it's been a pattern that I've seen, right? I've experienced, racism, Islamophobia, being kicked out of the operating room because of a hijab, having kids in residency and being told you're never going to be a surgeon. I've dealt through all of that in residency. But as an attending, things don't get better, right? You're all told, oh, just go, finish your training and finish your schooling, and everything gets better. It doesn't, it actually gets worse, okay? So my first year of being an attending, I was reported while I was on call. Every single time. Every time I was on call, I was reported. Once I got reported for asking for the mechanism of injury in a trauma patient. Just doing my job as a trauma surgeon, but no, like how did the patient get injured? Oh, are you questioning our call that this is a trauma? How did they get injured? Like simply doing your job gets you reported. I've had orders canceled where I would round on my patients post-call or whenever and write my note, put in some orders. I would leave, the nurses would call my other colleagues and say, hey, Hussein put this in, I don't agree, can we change it? And my colleagues complied. And they would change everything that I would order. And I had my surgical skills and my decisions questioned multiple times. I had a patient who coded in a trauma. I did a thoracotomy. The next day I'm signing out and I'm telling them, we did a thoracotomy, this is what we found with patient. We took the patient to the operating room and she's in the ICU now and this is what needs to be done. And the patient actually survived a thoracotomy. And this guy could not help himself and was like, wait, you did the thoracotomy? And I'm looking around like, who else is supposed to do it? Right? When you have to do a thoracotomy, it's an instantaneous decision. You have to make that, you have to make that decision within 30 seconds. Am I expected to call somebody to come and do a thoracotomy for me? So we think that things get better after we finish. They actually don't. So this has been a behavior that I've experienced throughout my first year as an attending. So This is what we call a hostile work environment. It's a result of harassment, whether it's physical, sexual, or verbal, result of discrimination based on race, gender, ethnicity, or religion, or aggression, just pure abuse and bullying. So what are the risk factors? What puts you at risk of experiencing all those things? Being a trainee, right? You guys are medical students. Some of you guys are residents. Being a trainee, you're in that middle ground. You're no longer a medical student, right? But you're not yet a faculty. And everybody, including nurses, your attendings, patients, you're an easy target. When I was a resident, I was called a terrorist N-word. And what support did I get from my institution? Zero. So I teach this because as people who are targeted, you have to be the leader in changing this because nobody else will. Nobody else will address this. So you have to have the leadership skills to challenge these things, right? Gender, being a woman puts you at risk of experiencing these things, and ethnicity. And what does it make you feel? It makes you feel uncomfortable, scared, and intimidated because you're in a hierarchical system where you have little to no power. And when you do speak up, guess what? Repercussions and retaliation, right? So there's a real risk to speaking up because there are repercussions. What's the impact? What's the impact of experiencing hostile work environments? It's actually a lot, right? Workplace harassment causes stress that actually leads to physical and mental illness. High blood pressure, depression, stress, cardiac disease. It impacts your job outcome. Your ability to do your job is impacted, right? Your family well-being. You take what you experienced in the workplace and you take it out on your family. So the impact of this is great, and the fact that we ignore this stuff is really heartbreaking, okay? And this is a scary statistic. This was a study that was done after a group of emergency medicine residents took their in-training exam and they were surveyed at the end of it. A total of 7,680 EM residents. 45.1% of them said they experienced workplace mistreatment, and 2.5% reported that they had recent, not ever in their lives, recent suicidal thoughts. That's 192 EM residents in 1 year. Imagine if they all acted on it. Imagine if 192 EM residents died by suicide. So this is serious stuff, and the fact that we take it so lightly and that we address it with implicit bias trainings and diversity, talks, I believe is something that we should all be concerned about. And it also causes actual impact on our patient care, okay? And one study found 13% increased post-op complications. 13% post-op complications. Why? Because of workplace harassment. People are scared to actually bring up issues so they could prevent complications. And collateral effects. So it's not enough that you just experience workplace harassment between two people. Anybody who observes it and sees it is impacted. Their productivity goes down. Their ability to do their jobs well is impacted because they observed it, right? They didn't experience it, they just watched it. It's like a contagion that spreads. So how do we address it? Through a culture of silence. We don't talk about it, right? A business theorist, Chris Argyris, calls it the undiscussables and their undiscussability. We don't talk about it, and we don't talk about why we don't talk about it. Let me see. Do you guys know the rules of Fight Club? What is it? Don't talk about Fight Club. What's rule number 2? Don't talk about Fight Club. It's like trauma, right? All the same thing. Or the people who don't know Fight Club. Do we talk about Bruno? Can I get a chorus? We don't talk about? We don't talk about Bruno, right? Silence, we say nothing. And this is why it remains understudied and poorly understood, right? We don't talk about it, so we don't study it, and we don't understand it, so we don't know what to do about it. And that's why you have to be leaders in addressing these things. Every institution that I've ever been in, every encounter that I've ever had, I had to be the one to lead change. I had to be the one to ask for and advocate for what it was that I wanted. Maternity leave policy, we didn't have that. I had to create it. My program director's solution, oh, you're done. You're not gonna be a surgeon. That's their solution. Their solution is, it's never been done. We don't do this. Operating room and hijab, yeah, it's not done. You know, you gotta go do something else. Their solution is that there is no solution. So we have to be the ones to come up with it. So what is the solution? Anybody ever heard of the FIO protocol? Anybody? FIO protocol, figure it out. You have to figure it out. And who are the people who are gonna figure it out? Who are the people who are invested in it? Exactly, the people who are impacted by it, because everybody else, there is zero incentive. There's actually negative incentive, because if they change things, it might impact them in a negative way. If they say we have to have salary equity, guess what? They're either gonna make less money, or they're not gonna get raises as often or as much as they would like, right? So there is zero incentive for anybody to fix a system that's benefiting them. So we have to figure it out. And we have to figure it out by getting comfortable with difficult conversations, right? It's scary, it's painful, and it's risky, but we have to get comfortable with having difficult conversations and having them intelligently, having them strategically, okay? This is called crucial conversations in other literature and certain books. But we have to also stop using all these different, crucial, no, let's talk tough. Let's have a difficult conversation. It's gonna be painful, but we're gonna talk about it. They're high stakes and they're high opinions and there's a lot of emotion. We have to be able to manage these because we are actually dealing with life and death, right? When you guys finish, you're gonna be leaders. You're gonna be dealing with life and death, and if you cannot lead in a life and death situation, it's gonna be somebody's life that's gonna be depending on it. Okay? So first, we have to break the silence. We have to change this culture of just going through the motions and just letting things slide, because that's what helps maintain the status quo. So we have to make the undiscussables and their undiscussability discussable. That's a very good paper, by the way. Get comfortable with the uncomfortable. How do you do it? It's easier said than done, right? And it takes practice. It takes practice, and I promise you it gets easier. So these conversations have to be face-to-face. This is not through email, as per our last conversation, right? The passive-aggressive voice. No, these are face-to-face. This is not through text messaging and not through emails. These are face-to-face conversations. The conversations are clear and direct. What was it that you said earlier?
Just like clear communication.
Clear communication. I want you to place an IV. I want you to hang the blood. Right? There's nothing ambiguous about that. You have to be clear and direct. You have to acknowledge the situation. What did you say?
Lose the attitude. Lose
the attitude. You have to acknowledge. It's hard. I know y'all laughed at him at first, but he was right. Okay? It's hard. It is so hard, but you have to acknowledge the situation. And then we're gonna go through what a debrief is. Have you guys heard of debriefs? Okay? I don't know if they're teaching it in medical school right now, but it is one of the most essential things that is undertaught. It's a powerful tool. If you learn how to debrief appropriately, if you learn how to debrief effectively, it can change things. It can change how your team functions. And you have to set expectations, right? People can't meet your expectations if they have no idea what your expectations are. This is a lot of the problems that we have in miscommunication, right? You expect someone to do something, but you haven't told them. What? People have telepathy? So don't expect telepathy. Say exactly what you want to be done. And if it's not done, then you can talk about that. But if people have no idea what it is that you want or what it is that you need, then it's really, really hard to hold them accountable. Okay? So what happened with our patient? So after the third time, and now our blood pressure is in the 70s, I said, okay, you hang the blood. Can you do me a favor and hang the blood? I see we have an IV. Can we get another IV? Can you place another IV? Okay, I got it. Blood pressure starts going up a little bit, the blood transfusion is going in. Well, now our blood pressure is 90, so we're good. And I said, everybody, stop. I need everybody to stop and look at me. Well, I said, okay, this is Dr. Hussein. Can everybody see me? I need everybody to stop and look at me. We have an unstable patient who's going to bleed to death unless our team gets our act together and takes care of her. So I need the attitude cut. That's exactly what I said. I need the attitude cut, and I need closed loop communication. When I give an order, I need whoever's going to carry out that order to tell me they heard me, to say, doing it, getting the blood, placing an IV. Clear and direct communication, closed loop communication, right? You can say all the clear stuff that you want. If they haven't heard you, is it clear and direct? But that closed loop communication of them stating that they heard you and that they're carrying it out. Or I say, give blood, and they're like, getting NS. Like, no, 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 I didn't ask for NS. I asked for blood, right? Closed loop communication ensures that they heard you right and that they're doing what you asked, okay? Closed loop communication. And I said, let's cut the attitude. Then, and last thing, I want you guys to start moving faster because this patient is going to bleed to death unless we do so. So things started moving a little bit faster. Okay, so we talked about clear and direct instructions, acknowledge situation and patient status and work environment. So I wanted to stop here and discuss the risk associated with that. Okay, I was able to start saying this as an attending because I was able to accept the risk that came with it, right? The risk of getting reported, I'm like, I've been reported a whole bunch, added to the list, right? But as a student, as a resident, when you do speak up, and depending on what you say, there is retaliation, and that retaliation is real. Some of that retaliation is now having a target on your back, right? Now being targeted and being nitpicked and being put on performance improvement plans, right? So I don't want to give you guys this advice without telling you guys of the real risk associated with speaking up, right? You have to know what the risk is and you have to be willing to take it. There were ways as a resident I dealt with this. I had attending yelling at me. I wanted to yell right back and put him in his place, but you know what? I knew what that was going to do to my career and my future. And so my way of dealing with that was walking away. He kept yelling at me and said, Qaali, don't walk away from me. I said, gotta go see a patient. You have to find ways and strategies that take you out of these hostile environments, these toxic experiences, but at the same time protect you. And this is what I've seen in a lot of places that are not taught. Nobody teaches you this because a lot of the people who are doing this stuff haven't gone through it, haven't experienced it. They're like, yeah, speak up. But what does that do to somebody who's already a target? As soon as they start speaking up, what happens to them? They become more of a target. You're a victim of a hostile environment, and now you become a victim of retaliation. So I want you guys to take this, and I know why you guys all laughed. You're like, yeah, right. How are we going to do that? Because there's a risk associated with it, right? And that risk is very, very real. Okay? And then almost on every single case, make sure you don't forget patient care, right? We're all here to take care of our patients. And then debrief. This is what I'm going to talk about in a little bit more detail. So a debrief allows the participants of whatever just happened to discuss both individual and team level performance, identify any errors made, and develop a plan to improve their next performance. And so the basis of the debrief and how I do my debriefs is to always seek first to understand and to be understood. Do you guys know who Stephen Covey is?
7 Habits.
Thank you. Y'all should read that book. My 13-year-old daughter's computer sciences class, her teacher teaches that in middle school. It's a powerful book. Okay, so 7 Habits of Highly Effective People. Seek first to understand, then to be understood. Right? Always start with curiosity over accusation. As soon as you start accusing people, if in any of these, in almost all of these things that I've experienced, is it because of racism? Is it because of Islamophobia? Is it because of sexism? I don't know. It's really hard for me to tell. And if I start accusing, oh, are you treating me like this because of, any of those things? What do people do when you accuse them of stuff? They become defensive, and your dialogue is done, right? So the whole point of having a debrief is to create a dialogue. And as soon as you start accusing people, the dialogue is done, okay? And then assumptions. When you assume people's intent, when you assume what errors people committed, you're already putting them in a situation where you're almost, similar to accusing them. They're going to be defensive. So always start with curiosity. So this is how I do a debrief, okay? The first thing I always ask is, how do you think that went? In almost all situations where things could have gone better, I always start with, how do you think that went? I know how it went. That was terrible. That was awful. But somebody who hasn't done trauma and this is their first or second experience, this could have been like a great experience. Like, oh, that was fantastic. So, and it's important to start this way because as a leader, what's your goal? What is your goal for your team and your team members as a leader? Efficiency, and you're trying to get people from where you want them, from where they are to where you want them to be, right? You have a goal of how your team should function, how things should get done, right? That's your goal. You don't know where people are along the spectrum. You don't know where people are. You could have somebody who's been doing this for 30 years, right? Some of the nurses I worked with have been doing trauma longer than I've been alive at the time, right? So they're all the way over here. They're the ones starting, at the beginning of the debrief saying, this should have been done, this should have been done, that should have been done. That's a team leader for me. That's someone that I can rely on to say, hey, I need you to keep an eye on this. Versus someone who's like, oh, that was the best trauma I've ever seen, who's brand new. So it helps you identify where your team is along that trajectory, okay? With the exception of one case. So in cases where we did everything we possibly could to save a life and we lost, and I know everybody did their part, I don't start with how do you think that went. I start off with thanking everybody for their hard work, because acknowledging people's work, acknowledging people's hard work goes a long way into creating a really good team that's going to give you their all every single time. So when you have a chance to thank your team, right? You lost a patient, everybody's sad. That's a traumatic experience. You lost a patient, whether it's in the ICU, in the operating room, in the ER. The first thing I do when we do a debrief after a death is I thank my team. Like, we did a very good job. You guys, I really appreciate every single person who tried, but we just, couldn't get there. So it's important in team building. And so after I ask, how do you think that happened? Or how do you think that went? Then I ask them, what do you think happened, right? Help them identify the problems. If I tell them, you did this wrong, and you did that wrong, and you did that wrong, they're gonna have zero investment in changing anything, right? Have them identify the problems. What do why do you think that happened? Have them figure out, okay, what could have been done better? Why did this thing happen? When your team is involved in the solutions, when they're involved in identifying the problem and the solutions, guess how invested they are in solving these problems? They're going to be very invested, right? There's a lot of literature to show that when the solutions come from the people who are going to be implementing them, it's much more effective than if, corporation or a leadership or someone who has no idea what's going on, down in the trenches comes in and says, now we're doing this. When the people who are doing the work come up with the solutions to the problems they've identified, you have a much better chance of things actually working and improving. Okay, so at the end of the debrief, you identify the gap. What did we do wrong here? Right? Okay, things were moving slow. We weren't listening. There was an attitude. They identified the fact that there was an attitude. And their response, the underlying problem was, well, Dr. So-and-so doesn't do it this way. I said, that's Dr. So-and-so's way. My way is different. I do things systematically. I don't skip over stuff. I do it systematically, and I do it the same way every time. Right? We come up with an improvement plan from now on. Okay, so you want things done this way? Okay, that's what we're going to do from now on. And then we set expectations. So this was my first debrief with them, especially with this, with a patient this sick. And I set my expectations. I said, from now on, this is what I want done, right? If somebody puts, patient on the monitor, I need somebody on IVs, I need a manual blood pressure right away, and if we need blood, as soon as I say blood, somebody says blood and they go and get it. This is my expectation. And then you keep repeating it over and over and over, no matter how bad the situation is, debrief after debrief after debrief, and you learn and you continue to grow. And this very team with the, we got it, chill people, became one of my best teams I've ever worked with. We got to a point where I would come in and just stand in my spot, everybody had their assigned roles, and they would just tell me when they needed me. I didn't have to call anything out. When I needed to cut somebody, they knew. I'm like, okay, if the blood pressure goes like this, or if the chest x-ray shows this, I might need to place a tube. Chest tube, you gotta cut the chest, they give me the knife, the scalpel. Right? They became so efficient that we started timing ourselves. The time from when the patient hit the door to CT scanner or the operating room, 6 minutes. 6 minutes is our record. Yeah. We try and do it less than 10, but so because we're able to have difficult conversations, and it came to the point where within our assessment of the patient, there was a time when they're like, Hussein, we can't hear you, because I'm short and there's a bunch of people that are taller than me. Step stool. Stood on the step stool, manage the trauma. Like, it's continuous back and forth. It's not me just calling out things, it's back and forth. It's an open conversation where hierarchy doesn't matter, right? So what is the solution? The solution is for us to figure it out. The whole process of having difficult conversations allows that. Embracing these difficult conversations allows us to find out what the problem is, identify the problem, and solve it. But does this really change culture? Right? What we talk about, hostile work environment, is more of a cultural issue, right? It's more of a company culture, the culture amongst people. Does it change anything? And so another night I'm on call. This is about 2 years in. I get a page from the charge nurse, we need you in the ED, please. I can't get a hold of the ER physician. I'm like, I don't see a consult in my computer. No, we just need you. And most of the times this means the ER physician is in a really terrible situation and they need trauma to come in and help. So I rush downstairs. Like, what is going on? And surprise, I walk in, 2 of our nurses are wearing this full-fledged hijab. They made it out of bed sheets. And I'm like, what in the world is going on? And they wrote on it, Hussein's hoodie crew. Like, what is wrong with these women? Like, are they trying to, my BFFs? What is going on? Like, is this a way to make friends with hijabis? Is that what they learned? And so, the story behind this is, over the years, this has been like 2 years by now, we've gotten to a point where we were having difficult conversations about patient care. We started having more intimate conversations about our personal lives, right? They would ask me, what is Islam? What is Muslim and Islam? What's the difference? And I realized that that knowledge gap was so deep because this is a small town in Florida, an hour from Tampa. And majority of the people that I've worked with, the people who've been reporting me and the people that I've had these terrible interactions with, they've never seen anybody that looks like me. I think we were like one of 2 or 3 Muslim families in the whole place, and we were a small group of black people that lived in the entire city. All their lives, they've never left this town. And so when they met me, it was like, who the heck are you, and why are you all up in our face? And so part of the negativity was that they were too afraid to ask questions. And so as we started having difficult conversations about patient care, they started approaching me and asking me questions about my religion, my culture. Where is Somalia? Is that in Asia? Seriously, you have to pull up a map like, that's Somalia, it's in Africa. Right? We started talking about politics. All the taboo stuff that you're not supposed to talk about, we started talking about that. Honest conversations, right? No emotions, I was having conversations with white Christian women, and we were talking about family, we were talking about our religion, we were talking about the similarities between Christianity and Islam, right? No amount of implicit bias training gets you to that conversation. So they did this because they started reading about Islam and hijab on their own, and they found out it was World Hijab Day. I wasn't online this time. I was completely off the grid, so I had no idea. I haven't even heard of World Hijab Day. They found out it was World Hijab Day, and they wanted to show me that they supported World Hijab Day and my faith. And that's how they showed it. And they taught me about World Hijab Day. Now, is that culture change? I think so. But I think the most impactful story about culture change and how embracing difficult conversations is really, really impactful is the story of my friend who, after having conversations for 3 years, the 3rd year of our friendship, she said in Thanksgiving, she finally had a conversation with her dad, who, when she was growing up, it wasn't odd for her to hear racist slurs growing up. And even to this day, she says, he's been saying it in front of my kids. And I never found the words or the courage to speak up to him. And that Thanksgiving, she told her dad, "You're not going to speak to my kids or in my presence like that." And she changed her children's exposure to racism because she embraced difficult conversations within her family. So simple, difficult conversations can have a ripple effect. If we really embrace having those difficult conversations, and we started off, we're in a great place to have those conversations because as a group of healthcare workers, we have something in common. We all have the same goal of taking care of patients. When we can honestly and openly discuss how we provide great patient care, and we can have difficult conversations there, it becomes so much easier to tackle the more difficult, the more emotional, the more personal conversations. Okay? So I pray that you guys start those ripples that turn into tidal waves by embracing difficult conversations. Thank you.
We'll take 10 minutes of questions. Sean? Questions?
Jazakallah khair for sharing your story. I guess my question is, where do you kind of draw the line between embracing these difficult conversations and making a change versus walking away from a situation because it feels like change won't happen or, it starts harming you? I guess kind of finding that balance and deciding where that line is. How have you found that in your own life?
So I think you have to draw that line for yourself, okay? I had to make that decision for myself not too long ago. My first job out of fellowship was in Florida, and things were heading, I was there for 4.5 years, pushed for a lot of changes, right? This is the very same place, pushed for a lot of changes. You have to know a point of what I call futility. When you reach a point of futility where you give so much and you don't see change, right? So for three years, all my efforts were paying off. Things were moving, right? Things that I instituted in the ICU, in the ER, in the operating room, I was seeing change from my efforts. When I stopped seeing change from my efforts and I was just burning myself out trying to change things, when there was no result, then I had to make the decision for myself that this is not worth it, right? So you have to know at what point do I define futility. And for me, it was when there was no longer response to my efforts and I was actually putting my license at risk. Right? Things were happening where if I continued to go along, I would put my name, my license, and everything that I worked really hard for on the line. So you have to make that decision for yourself to say, at what point is it futile, right? If you try and the result is more pushback and more retaliation, then that tells me that that place is not capable of change. Right? Your first few efforts, if the response isn't, okay, fine, what do you want to do? And they actually listen to you and take what you have. They may not go all the way, but they make a step towards improvement, then you know, okay, this place is capable of change. And that my trial, my first year, that was my decision. Like, if I really embrace this difficult conversation and I really try and move things along, and things don't change, then I'm leaving, right? But things changed, things improved, and so for 4.5 years, things were going great, and then things changed. Administration always changes. You'll learn all about all of that. Nothing is consistent. Things changed, and then my efforts were no longer, supported. And so at that point, I said, it's time for me to cut ties. And so always have that option available to you. That one of the problems that I think medicine teaches us is to tie your identity and your accomplishments to institutions. Right? I am part of this institution. You'll never see me write what institution I'm part of or what hospital I work at, because my identity isn't defined by who I work with or where I trained, right? My biography will say all of that, but when I introduce myself, I don't say I work for this, and that place, because that relationship is not permanent, right? And an administration can change, and all of a sudden they can decide, you know what, you're no longer what we want. I mean, my first year training in residency, the education committee sat around, really asked, should we ask Qaali to take off her hijab? And lucky for them, somebody was in the room who knew better and said, you shouldn't do that, right? But why? Because this is not the image they wanted for their school. So any institution that you work for, unless it's a company that you own, that relationship isn't permanent. So defining your accomplishments, defining your identity based on that connection, I think that's where things get a little dangerous, right? Especially with the big name schools. Like, you're supposed to give up, the money that you can make in private school and to stay in academics because, I'm part of this big academic center. I'm sorry, I'm biased when it comes to that. Oh, there.
So right now, like in the hospital system, or as medical students and future residents, we have a hierarchy system. And sometimes when you speak out directly or indirectly, like you mentioned, there's the retaliation system. You spoke about walking out of the room and going to, say, have a patient to see. Can you tell us about instances where you had to deal with those retaliations, and how did you deal with it?
So, let me tell you, should I tell you guys this story? Yes? So I had this experience where I'm trying to figure out which story I want to tell you, because there's so many of them. It's bad. I had this one attending who, regardless of how hard I worked, just never really saw me as a surgeon, right? I kept having kid after kid after kid. Like, intern year, I have an intern baby, second year baby, fourth year baby, chief year twins, and a fellowship baby. And so every year I was pregnant, and they were all convinced that you're not a surgeon, you're just pretending to be a surgeon. And so one of the forms of retaliation that I saw was that I was not getting taught in the operating room. Like, I would ask questions, and I would read ahead, and all my questions were answered with yes, no, or I guess so, read the book. And so I walked in one case with one of my other colleagues, same year, and he's operating with this attending, and he's showing him all this cool anatomy and teaching him all these different techniques, and it just angered me so much. Like, I'm working really hard to be here and leave my kids every single day crying just so that I can work on my skills and become a surgeon, and this is how I get treated. The same investment that they're making on every other resident, I'm not getting. And so how are you going to report that? Oh, he's teaching him, he's not teaching me. Like, there's nothing you can do about that on an outward way. But internally, I could take ownership of my own education. And so I bought all the books, and I read, and I read, and I read, and I read old texts, and I knew history, and I knew old techniques, and I knew new techniques. And so when I'm in the operating room and they're not teaching me something, I'm like, oh, I read this, and you could do this, and you could do that, and you could do this. And what is their response? They roll their eyes, right? But if I took what he thought of me and why, what was important to him, because we have completely different value systems, right? I value my family, but I also value my career. With him, it's career over everything else, right? And so we don't have, the same value system, so we're not gonna see eye to eye. So I took responsibility for my own education, and I stopped valuing what he thought. Right? I'm like, I understand. You guys think I'm not going to be a surgeon? Fine. Just let me finish my rotations. Let me finish what I need to do. Sit for my boards. Get board certified. And you have no say in whether I can become a surgeon or not. Right? At a certain point, it becomes those people who feel like they have power over you don't. A lot of times we give people more power than they think they have because we value their opinions. So the moment I learned to stop valuing people's opinions, just like, okay, teach me this. Like, this is what I did with another attending who, every chance he got, he would find a reason to criticize my personal choices of having kids and this and that. But he wouldn't teach. When he was teaching, he would teach well, but he would always change the conversation to making it personal. So what I learned to do with him is always run the conversation. Always run the conversation to, okay, what about this? What about that? As soon as he started talking about personal things, if I wasn't operating with him, I left. I'm like, oh, I gotta go see a patient. But in the operating room, I ran that conversation. If he talked about personal lives, I would either laugh it off or, because we had the same kids the same age, right? So I would either change it to something good, or I would say, okay, let's not talk about that, teach me this. And so take ownership of your own education and take ownership of a lot of these conversations. And if they're not serving you, remove yourself from the situation. There's no reason to sit there and put yourself at risk, put yourself in a position where you have to experience this. Find a reason to get out of the situation.
So I read up about you a lot, and I admire you so much.
Thank you.
I have a couple of questions. So can you talk, and I know I walked in a little bit late, so I apologize for that. Can you talk about how you managed to have, did you take time off to have your children, or were you having a child and then back into residency? How did you do that?
I wouldn't recommend what I did. Let me preface that with this. I had my first child my intern year. I had some time before I gave birth for, I had sciatica, so I had bed rest. And then I had the baby. I came back 4 weeks later. My second year, I came back 2 weeks later. My fourth year, 2 weeks later. My fellowship, my chief resident, I had to make up 3 months. And I was pregnant with my twins, so I finished out my 3 months. I did some locum stuff. I had my twins, and then I came back to work. I came back, did a fellowship, and then had my fellowship baby. And I think I came back 3 days later because there's this pediatric. I'm explaining. Oh my God. I'm explaining myself. I came back 3 days later because there was this pediatric ICU rotation. I was an ICU fellow. I was a critical care fellow. I was like, I really, really wanted to do this PICU rotation. And so I came back, and I was three days postpartum, and I was struggling, and I was, leaning on the wall. And some, passive-aggressive pediatric attending wrote that I was uninterested. And I canceled that rotation. I took the rest of the month off. Yeah. Mm-hmm.
And I feel like I have to I combat a lot with the culture of surgical residency. It's all of them, what do they do after they go to the bar and drink? I'm a Muslim, I'm not gonna do that. And so that it kind of was one invitation, I said no, and then now it's just kind of been oh, she doesn't come out and hang out with us because she thinks she's better than us, or something like that. And then it's just kind of translates into my professional work life. I don't get the coolest cases to do whatever's at my level at this time. They don't give me the cooler cases. They'll give it to my co-resident who does go out with them, and it just feels very unfair. It's well, I have a value system that I hang on to, so I'm not going to compromise that, but also too, I feel my training's being compromised because I'm not buddies with everybody.
you're doing the right thing. I mean, you said the right words, value-based. You know, you make your decisions based on your values. You're not compromising who you are to fit in. You're already there. You just have to now deal with the consequences, right? You're going to make connections. I know other maxillofacial surgeons, so professional. That's one of the reasons why I love the fact that you guys did this, and mashallah, you know, to you guys. I have a Defiant Career Women, you know, conference coming up next year, inshallah. We need to create our own networks with people who have the same values as us, so we can have the same professional networks. Right? You don't need to compromise your values to fit in. I've never gone out with any of my residents. When did I go out with my residents? Our chief roast, when somebody dressed up, you know, like me and was pregnant every other day for 5 days. It's hilarious. You don't need to go out in order to make those connections because you don't have the same value systems as those people, right? Networking is important, but you need to network with people who have the same values as you. And if there's a discrepancy in how the cases are getting, you know, distributed, then make connections within the place and say, hey, I want to do these cool cases. I'm really interested in this, right? You know how I got to do my first thoracotomy? I'm going to tell you. I think every chance that I tried to do it, there was a senior like pushing me out of the way. And it was like, sadly, it was like my 4th year that I actually got to do the thing from beginning to end. And my chief resident is there, he's going into plastics. He's not gonna need to do this. And so I asked, I was like, okay, should we go in the chest? And attending was like, yeah. And then he's like, Josh, get ready. And I was like, I got ready quicker than Josh. And I stood over here and I said knife. And my attending, he's looking at me, he's like, have you done this before? I'm like, no, knife. And he gave me the knife, and he's like, okay. Went in there, did the thoracotomy, found a hole in the heart, sewed it up. And then at the end, you know what my attending says? Josh, you're giving up thoracotomies now, huh? And I was like, I don't think he gave it up, I just took it. Yeah. So sometimes you have to seize opportunities.
So, besides having like the difficult conversations and stuff, we should definitely align ourselves with people who have the same values and whatnot. But if we don't, per se, fit into the specific demographic that's facing like the discrimination or whatever is going on, how do we best ally ourselves with those folks?
With the folks who are what?
On the end of discrimination.
Who are on the receiving end of discrimination?
Yes. Say I was Josh.
Uh-huh.
No idea.
Then you speak up when they can't, right? When there's real repercussion and it's really hard for you to speak up. If you identify a problem, you speaking to it as Josh is probably going to carry more weight than, you know, somebody else who's at the receiving end, right? So allyship, you know, saying hashtag Black Lives Matter, hashtag anti-racism, there's no meat behind it. There's nothing, there's no substance. But if you can take on the risk of speaking up, you know, not on behalf of that person, but to the situation and say, okay, I see, you know, these things are being done, or you see that a certain nurse is, you know, continuing to target a resident. Can you talk to that nurse, or can you talk to somebody above her and say, she's constantly picking on this resident? Why? Why is she always questioning him or her? Right? So if you can take on the responsibility or even the risk of taking on the difficult conversations that some people may say, you know what, it's too risky. A lot of the conversations I couldn't take on as a resident because I knew the repercussions and I wasn't willing to take that risk. Right? It's always a risk-benefit analysis. Right? We continue to stay silent because the risks are too high. Right? The risks are too high. The retaliation is real. And so the culture, that has these repercussions and that continues to target the victims of hostile work environments isn't really conducive to difficult conversations, and especially coming from the victims. And so if you can take on that conversation and have that difficult conversation and say, why is there a difference? Why is this resident being held back? Why is this, why is this resident having a performance, improvement plan written on them when another resident did the same thing? This is what we do. So I'm also a co-founder of Black Doc Village, which is a nonprofit organization that is addressing the issue of the disproportionate dismissal of Black trainees from residencies. People are getting written up 3 weeks into intern year. Everybody needs to improve 3 weeks into intern year. But we had to deal with a black resident who was written up and put on a performance improvement plan 3 weeks into intern year. And she's the only black woman in the entire residency in 3 different hospitals. Right? And who is she going to complain to? Right? And as soon as you say it's racism, conversation is over. As soon as you name the problem, dialogue is done. Because people automatically say, we're not racist. So I think the best thing you can do to be an ally is to actually get involved in those discussions. There's 2 people. I'll take her first.
I have a little bit of a tangential question going back to the statistics you shared about the emergency medicine residents and just kind of the downstream effects of a hostile work environment in general, specifically on residents, and how it leads to things like depression and stress and even like suicidal ideation.
Yep.
I was just wondering, like, as we're medical students preparing to apply for residencies and knowing that that's going to take a toll on us emotionally, regardless of, you know, our ethnicity or religiosity or gender or whatnot. I was just curious about if you have any experience on unionizing residency programs, because it's a big topic of conversation right now, especially after the COVID pandemic and the, you know, the heightened stress that residents were put under unexpectedly. So I was just wondering if you could speak on that.
I think it would be great if residents were unionized. There is a residency in New York, I want to say. I'm not sure of the details, but there is a residency that has recently unionized. It might be in Vermont. UCLA unionized. Who else? California? There's a couple. So look those up and get connected. Maybe AMMSA could get involved. I don't know. But I think I've been asking for years, but the movement, you have to have community, you have to have people, and you have to have support. But I think we need to head there. We definitely need to head there. Last question. Is that why you're working?
Well, at this point, I'm considering you a superwoman. But if you touched upon it a little bit, in terms of, obviously, we're med students, there is an obvious power dynamic that exists between us and our attendings. But not only that, we are in a temporary position. Like, most of our rotations are 2 to 4 weeks. We don't really spend that much time with the attendings. What are your thoughts on how we can advocate for ourselves and for our patients that exist in such a, starting those conversations in a temporary position?
Anytime you have an idea or a suggestion, I think asking a question, I think curiosity is like this magic thing. You know, I just ask, oh, Dr. So-and-so, what do you think about this? Or I saw this patient and I'm thinking, and this came to mind. Do you think this is an issue? Do you think this is something that we should, you know, address? Right? You're not imposing on them and saying, I think we should do this. But asking those simple questions goes a long way. Right? You just plant the idea and they're like, oh, that's great. You came up with the idea, but now they're thinking of the solution and they're going to take credit for the solution and say, oh, right? So I think curiosity is a really, really powerful thing to navigate a lot of these spaces. And another thing that I want to add, and I think this is important, I had a resident come up to me and tell me this, and it's been one of the things that changed the trajectory of my residency. People have impressions of you without you even saying anything, right? They assume the stereotype of you, and they have an idea. And so I ask a lot of questions, right? An attending tells me, order a CT scan. I'm like, why are we ordering a CT scan? What are we looking for, right? And so I do this to I did it to everyone because that's my way of learning, by asking questions. I had one particular attending who thought I was questioning her and her ability, and so she thought I was cocky. She thought I was insubordinate and that I knew more than her, even though she told me I didn't know how to operate and I should quit. But I had a senior resident come to me and say, Qaali, this is her impression of you. He's like, I know you ask a lot of questions because you're just, you know, you ask too many questions. That's your problem. But he's like, I know why you're asking because that's how you learn. But she doesn't know that. So go talk to her. That's the best advice I got. So I went and talked to her and said, oh, you know, I just wanted, and I asked it in a way to say, I just want some feedback. It's halfway through my rotation with you, and I just wanted to know how I'm doing. And she's like, oh, I have a problem with you asking me questions all the time. And I said, but this is how I learn. I read something in the book and then clinically I see variations. And so I just want to know how you're thinking. She's like, oh, okay. She started sending me articles. When I was on bed rest, she sent me a job where I sat in my bed and like wrote cases, and I got paid like really good money for it. And she became one of my biggest supporters. And from then on, every rotation I did, halfway through the rotation, I went to my attendings and said, hey, I just wanted to get some feedback. How am I doing? What can I work on? What can I improve on? When you do that, when you ask those questions, when you ask for feedback in how you can get better, they see that you're interested. Right? They see that you're actually invested in your learning, and they will invest in educating you. One of the most toxic people that I've ever worked with, I had the best relationship with him because why? I asked him a bunch of questions and argued with him all the time, and he's like, you're hard-headed and stubborn, but I like it. And he taught me a lot. He taught me critical care. He was a pulmonologist. Taught me all the critical care that I know. So don't be afraid to seek feedback. And I'll end there.
إلا الله لا إله إلا الله لا إله إلا الله ما لنا